is critically means vascular disease of the cerebral circulation. It's also known as stroke. For most people, when you hear the word stroke, they really don't remember or realize that there are so many different kinds of stroke. Okay? There are ischemic strokes and there are hemorrhagic strokes. Ischemic strokes account for 90% of the strokes. So if you're going to see a stroke, it's probably going to be an ischemic stroke. Hemorrhagic stroke account for about 10% of the strokes. Now, there are subtypes of ischemic strokes. Most ischemic, ischemia means blood supply was cut off. Right? Who's here?
David.
David, okay.
He's on the line. I'm charging.
Okay. Most ischemic strokes are thrombotic. You know what that means, right? That means the clot is formed locally and interrupts circulation locally. But 20% of them are embolic, meaning that the clot was formed somewhere else, got into circulation, which we call embolization, and then occludes a right-sized vessel. Okay, because clots have definite size, and they will flow for as long as the vessel within which they're flowing is big enough to contain them. Once they get to a vessel that is of the same size as the diameter of the clot, they clog the vessel up, and that is when a stroke results. So that's an embolic stroke. And then there is this type of stroke called hemodynamic strokes. You see, the brain is supplied by three major blood vessels, right? Anterior cerebral, middle cerebral, and posterior cerebral. So, there are these areas called border zones. Border zones are regions that are between the territory of two major cerebral arteries. For instance, there is the cortical border zone, which is the zone between the regions supplied by anterior cerebral and middle cerebral. Generally speaking, in the border zones, the circulation is very vulnerable to low blood pressure. Because generally speaking, in this cortical border zone, it's like the anterior cerebral thought the middle cerebral will take care of it. Middle cerebral thought anterior cerebral will take care of it. Remember that saying that says there is a piece of task to be performed. Anybody could have done it, but somebody thought somebody would do it. At the end of the day, nobody did what anybody could have done. And everybody blamed somebody for the job nobody did.
You lost me at the first word. You lost me at the first word.
Okay. There's a bit of task to be done, right? Everybody thought somebody will do it. At the end of the day, nobody did it. And everybody blamed somebody for the job nobody did that anybody could have done.
It's like someone's down and you're just assuming somebody's going to call 911 and nobody does it.
Exactly.
Yeah.
So basically, there is anterior cerebral, middle cerebral, and posterior cerebral. Anterior cerebral supplies the anterior part of the brain, but the part of the anterior part of the brain that is close to the middle part does not get adequate branches from the anterior cerebral. And the part of the brain that is in the middle, that is closer to the anterior portion, does not get enough branches from the middle cerebral. Right? So these areas that have less branches of arteries because they lie in border zone are vulnerable to hypotension. So, if somebody codes, for instance, and you're able to resuscitate them and bring them back, sometimes they recover with a stroke because of the prolonged hypotension. If any part of the brain is going to infarct, is going to die as a result of prolonged low blood pressure, those infarctions are usually in the border zones. They tend to be multiple and they tend to be in the border zones. And they are typically described as watershed infarction. Okay? Watershed infarction. So infarction of the vulnerable border zones between the areas supplied by the ACA, MCA, and PCA. Okay? So the pathophysiology is low flow. So these are not thrombotic or embolic. They are actually hemodynamic or low flow infarctions. Okay? And the way you know them is from the history. They will tell you somebody suffered a cardiovascular collapse following a BP. They were revived in the field, brought into the emergency room, admitted into the CCU. They were stabilized cardiovascularly, but then they wake up and they have these multiple strokes. Usually those are watershed infarctions. Okay? And then 10% of strokes are hemorrhagic strokes, usually from aneurysms and AV malformations. There is something you need to know about the pathophysiology of stroke. Whenever there is a stroke, you have a core area and then you have the area around it. Remember in the heart, I told you when there is an infarction, the area around the infarction will be the injured cells, and around them will be the ischemic cells. The same thing happens in stroke. When you have an acute occlusion of a cerebral blood vessel, the brain cells in the immediate vicinity of that infarction, they will die within minutes if you have less than 10 mils per 100 milligram of tissue per minute. So if blood flow slows down to less than 10 mils per 100 grams of tissue per minute, they're dead in minutes. That's like your core zones. The brain cells in the ischemic penumbra, that is the area around the core, they will die when blood flow slows down to less than 25 mils per 100 gram tissue per minute. For a few hours. They survive only for a few hours. So that is why you don't really want to, whenever there is hypotensive episodes, even if you bring the heart back to normal, you have to worry about the brain and hope the patient did not suffer from a watershed infarction, which is a common complication of prolonged hypertension. You got that? Okay. So let's talk a little bit more about ischemic strokes. Ischemic strokes, there are two types, thrombotic and embolic. So thrombotic are due to thrombosis, locally formed obstructive clots, most commonly, or they could be in the arterial circulation or sometimes in the venous circulation. They are more commonly in the arterial, and they are most commonly due to atherosclerosis. Okay? But it could be due to vasoconstriction. Like, remember when we're talking about migraine, we talk about migraine strokes, right? When the vasoconstriction associated with migraine precipitates an occlusion and a stroke results from it, you can actually get a stroke or migraine. Or it could be a dissection, like somebody suffers a karate blow to the neck and something gets ripped and a clot is formed in the neck, and sometimes it can just occlude. Vasculitis or vasculitis is worth mentioning specifically. Whenever you hear about a stroke in a young person that does not have any atherosclerotic risk factors, so you hear a 26-year-old female athlete they may say has a history of systemic lupus or rheumatoid arthritis, some connective tissue disease, wakes up with right hemiplegia. You know it's a stroke. Generally speaking, that is the way vasculitis will be pitched at you. It's a young person. They have a history of some connective tissue disorders, rheumatoid arthritis, lupus, whatever. They have no atherosclerotic risk factors. And then it's about an acute stroke. That is the way vasculitis presents. Okay? And of course, thrombosis can also be in the veins. That's the kind of stroke you get with sickle cell, with polycythemia. You know, these are stasis, right? Stasis-induced clots. Anytime sickle cells, they will sickle and they will lose their ability, they lose their rheostatic. Lindsay talk about rheostasis. Rheostasis. Have you heard that word before? Okay. The ability of the red cells to navigate in circulation, change their shape to go through tiny blood vessels is called rheotaxis. Rheotaxis. So, in sickle cell disease, the problem is that the cells lose their rheostatic capabilities, so they're not able to negotiate because now the hemoglobin is coming out of solution and distorting the shape of the red cells. So the red cell is not able to change its shape to navigate the circulatory system, and then it causes a venous occlusion. Polycythemia rubra vera is when you have a lot of blood cells, white cells, red cells, platelets, a lot of them, in such a way that the blood becomes very viscous and very thick. And because of the stasis, the locally formed thrombotic agents that are normally diluted by shear flow accumulate in that region and they induce a clot. Are these familiar things I'm talking to you about?
Yeah.
Okay. And then you have hyperleukocytosis, is the kind of white count you get with acute leukemias, right? All of this, the first three, sickle cell, polycythemia, hyperleukocytosis, they have to do with cells. Thrombophilia has to do with deficiency or mutation in clotting systems, antithrombin 3, deficiency of protein C and S, and factor 5 Leiden mutation, you know, all that, thrombophiliacs. And then hypercoagulable states. So if I tell you that a 46-year-old, say, male, hypertensive, diabetic, and with a history of nephrotic syndrome, and I paint a picture of a stroke for you, and I tell you his last A1C was 6.9, his blood pressure is 130/80. What is the most likely pathophysiologic basis for a stroke? Arterial occlusion, venous occlusion, both, none. What would it be? Venous. Because by telling you that his A1C is 6.8, I'm telling you his diabetes is controlled. By giving you a normal blood pressure, I'm telling you that his blood pressure is controlled. So you may have hypertension and diabetes, they are well controlled. They are not going to lead him to have atherosclerosis. Then I tell you there is nephrotic syndrome. You should know that nephrotic syndrome is one of the hypercoagulable states. So his clot is likely to be a venous stroke. You got that? Okay. And then embolic stroke. You are your masters of embolism now. Atrial fibrillation, left valvular disease, dilated cardiomyopathy, mural thromboembolism, endocarditis, which could be infective or non-infective. And when it is non-infective, it is known as marantic. We talk about that. Remember? You remember marantic embolism? You better, because we talked about this in cardiology. Or it could be the Liebman-Sachs variety that you find in lupus. Did you talk about that in rheumatology? Yeah. Excellent. Okay. Marantic is a non-bacterial thromboembolic endocarditis. Endocarditis can be bacterial or non-bacterial. Okay. The non-bacterial kind of endocarditis is what is called marantic endocarditis. And the way you make the diagnosis of Marantic is usually you have somebody with endocarditis, you know they have endocarditis, but their blood culture keep getting negative, negative, negative. Once we begin to get repeated negative blood cultures in somebody with verified and diagnosed endocarditis, you're thinking more of Marantic endocarditis, right? And then you have the coronary artery bypass, right? When you're trying to do angio, I told you the story of the woman that came from Africa to get angio, and in the process of threading the coronaries, they scraped the plaque and gave a shower embolism in the brain, and that side damage. She went home in a casket, right? Even though she walked out there. So you can, from that, bypass surgery and also papillary fibroelastoma. We talked about that in cardiology, under cardiac tumors, remember? Okay, and then left atrial myxoma. So these are all cardiac sources of emboli, okay? And then emboli can be non-cardiac. Somebody can get a stroke from a DVT. All they need for that to happen is an ASD. If you have an atrial septal defect, a DVT that ordinarily should have been trapped in your lung can escape to the arterial side and give you a stroke. When you get that kind of stroke, or that kind of embolism, is called paradoxical embolism. Okay? So paradoxical embolism is an embolism on the arterial side by a clot formed on the venous side. How did the clot from the venous side get to the arterial side? There must be a shunt through which it crossed over in the heart. And most of the time it's an ASD or a VSD. Okay? And of course, carotid thromboembolism. The thromboembolic plaque in the neck sometimes can rupture and embolize. And that's why we do carotid ultrasound in patients with stroke. Okay? Are we good? Okay. There is a type of infarct that is given a special name. It's called lacunar infarct. The reason they call them lacuna means empty spaces.
Do we have this?
You don't have it?
No, not this one.
Okay, now you have it. So they call lacuna infarcts. Why don't you have it?
It was too fast.
Maybe I updated it.
The next thing.
What is your next slide?
Fast.
Don't worry about it. We'll talk about this. Okay, so well, just listen. It's not a big deal. It's just 2 bullets, a lot of pictures. You just need to know what it is. Okay? Lacuna infarcts. Lacuna means empty space. If you like, I can post it after the class. I'll post it so you can have it. Now, lacuna means empty spaces. The way they were discovered is really people have lived and died of unrelated causes, and then during the autopsy, you know, you've been to autopsy. Okay, when you did anatomy, did you dissect the brain?
Oh.
Okay. So you saw the way you dissected the brain, right? Like this in corona sessions, right? Or
Well,
did you
it
get
was
that?
already dissected.
Was it, how was it dissected though? Was it dissected like this or like this?
Both ways.
No, generally speaking, it's like this. Okay, because already, naturally, the brain is already dissected like this because of the hemispheres, right? But during those autopsies, they found that there are areas of the brain where they're like, the brain was like a honeycomb, just empty spaces. So the brain tissue contained in these cells just died. And because those parts of the brain are not involved in any vital function, the patients remain asymptomatic until they died of something else. And then during autopsy, you find these empty spaces in the brain that showed areas in which blood supply had been cut off and the brain cells have died. Then we started looking into it further. We realized that it happens only when the clot involves what is called a penetrating branch. A penetrating branch of the cerebral vessel is one branch that comes up and supplies a specific area. And what makes them unique is that there is no anastomotic connection with any other blood vessel. So they're like dead ends. You know, if you live in a close, you know, like a close, where they say not a cruise street. If you block the entrance to that cruise street, nobody can come in, nobody can go out. So these straight arteries called penetrating arteries, they are like dead ends to their areas of blood supply. So when you have a small emboli occluding that place, that those brain cells in the immediate area of that penetrating blood vessel, they will just liquefy, they'll be absorbed, and the space they occupied will be empty. And the patient will go around with that empty space until they die. And somebody finds out, oh, this person has had so many strokes. And they may not even have had any symptom. So that is all I'm trying to say with these pictures here, showing you what straight arteries are and what infarcts look like. What is important is that lacunar infarcts results from occlusion of terminal penetrating branches of cerebral arteries. They account for about 10% of silent strokes, usually discovered as empty spaces, lacuna, deep inside the brains of cadavers. Okay, you heard about multi-infarct dementia, right? Multi-infarct dementia is as a result of repeated recurrent lacunar infarction in some vital areas of the brain that gives you very slow but steady progressive memory loss and cognitive dysfunction. Okay? So, how does ischemic stroke present? Welcome back. You got this one. Okay. How does it present? FAST is what is now used for public education. You want to identify strokes. Face, ask the patient to smile. Ask the person to raise both arms. Speech, is the speech slowed? How long has it been? Okay, all of this is what everybody needs to know, right? So if you go, when you do your emergency room rotation, you see the doctors asking the patient, put your hand out like that, or like that. When there is stroke, the patient goes, right? Or they can't move off of their face, or they start talking like, so this slurred speech. Timing is everything these days, because it matters whether you go to the patient in 3 hours or more than 3 hours, or more than 4.5 hours. And that will become clear to you in a minute. "75% of ischemic strokes happen in carotid circulation." Okay? Remember, there are two major circulations to the brain, right? Carotid and what? Retrobasilar, right? Thank you. Right. So, 75% of strokes will happen in the carotid circulation. So basically, they present with cortical dysfunction, conjugate eye deviation, and sensorimotor disturbances. What are some of the cortical dysfunction? Cortical is another way we describe cognitive dysfunction. Okay, so when I'm telling you that there is no cortical input in what you're saying, basically I'm just saying that you're not thinking about what you're saying, right? Now if I tell you you operate at the spinal level, that means you're operating like an invertebrate. Okay, what makes us human is that cortical, that cognitive thing that we do have, where we used to think. There is evidence now that all these mammals can also learn, and they may have more advanced cognitive development than we once thought. Anyway, maybe one day the apes will take over the planet. So, cortical dysfunction, how does it present? You know all these already: aphasia, agnosia, anomia, amnesia, apraxia. You know all these, right? Okay. Can somebody tell me what apraxia is? Exactly, learn motor task. Failure to execute a learned motor task, right? And you know what anomia is? Show them the pen, say what is this? They can't name it. Okay? Okay. Now, you remember I kept telling you during dementia that dementia is not an acute process, right? So you see all of this you see in dementia, right? But usually on a chronic basis. Okay. In stroke, it's acute. I hope you understand. Don't get confused. They paint a picture for you and they put all these things there. It doesn't have to be dementia. Pay attention to the story they are telling you. Is this happening suddenly on the acute basis, in which case it could be a stroke? Or is this something that is chronic and going on for a while? In which case it's probably dementia. And then you have the conjugate eye deviation. You remember I told you about frontal visual field in the frontal lobe that is responsible for conjugate movement of the eyeballs. There is one on the right, there is one on the left. You remember that? And the one on the right move eyeballs to the left, and the one on the left move it to the right. Right? So when you have a stroke that involves the frontal lobe, and you take out the one on the left, then you have the unopposed action of the one on the right, right? So the eye will be deviated that way. So sometimes you see somebody with a stroke and you open their eyes and they're looking like this. It looks like they're looking at somebody, and people have, wondered about this for a long time. The most remarkable experience that I've had was we stood at the bedside of the patient, right? The head was that way. The son was standing there, and the attending was right here, and we were at the foot of the bed. So he opened the eye of the patient because the eye was closed. He opened the eye of the patient, and the patient had the conjugate division of the eyeballs to that side, and then the son broke down in tears because he thought that the mom was actually looking at him in a way that is like maybe mourning her own death or something like that, But mom has suffered massive stroke. She's not looking at you. That movement there is not, if you move over here, she will still continue to move over there. But the boy did not, he really walked away. Like, mom is looking at me like I'm supposed to do something. So she's not. That is part of the disease process. Okay. So generally it gives you conjugate deviation to the side of the lesion. Remember that. Okay? So the eyes will look towards the side of the lesion. Okay? And it has to do with frontal eye field infarction, which I told you already. Okay? They have all these sensory motor disturbances, hemifacial paresis. One thing I want you to remember and don't forget is whenever you have infarction in the carotid circulation, you tend to have hemiplegia or hemiparesis, but the emphasis tends to be in upper extremity. Okay? Because remember the homunculus hangs upside down, right? So the closer to the surface the infarction is, the weaker the upper extremity will be. Okay? So in this carotid circulation strokes, you get hemifacial paresis, and the arms tend to be weaker, right? Now, if you get a facial nerve palsy with it, it will be an upper sparing facial nerve palsy, right? Good. Now, the other part of the clinical manifestation, the remaining 25% happens in the VBA, right? The vertebro-basilar artery circulation. So these ones, of course, you know the vertebro-basilar arteries, right? The vertebral and the basilar. What is here? What is the brain structure underlying this vessel? The pons, right? And the medulla, right? The spinal cord. So whenever you have problems, not in the carotid, but in the vertebro-basilar circulation, you're going to get brain stem dysfunction, right? And what are the brainstem dysfunctions? Diplopia. Why do you get diplopia? Because you take out, the eye muscles are not able to coordinate their movements because some of the nerves are taken out. 3, 4, 5, 3, 4, 6, right? And then, so you get dysphagia. Well, brainstem controls a lot of your phonation and stuff like that. You get dysphonia, you get dysarthria, okay? And because generally speaking, cranial nerves don't decubitate, right? The lower motor neurons of cranial nerves don't cross. The deficit tends to be on the same side of the lesion, right? Okay. And then, remember this artery here? Your basilar artery divides into superior cerebellar. So the superior portion of the cerebellum gets its blood supply from the vertebro-basilar circulation. So in addition to brainstem dysfunction, you get cerebellar dysfunction, right? What are those? Vertigo, nystagmus, ataxia, dysmetria, dysdiadochokinesia. Remember all this and what they mean, right? So Bradley, what is dysdiadochokinesia? Demonstrate it for me. Exactly. Dysdiadochokinesia is when your patient cannot perform rapidly alternating movement of an extremities, right? And what is dysmetria? Exactly. They touch your nose and touch my finger, touch your nose and touch my finger, and the patient keeps going past it or falling short of it. All of those are signs, are cerebellar signs. You cannot forget these things. That is why the first class we did was pathophysiology, cranial nerves, and all that, so you know what these symptoms are. Okay? You can't forget these things. And of course, you get hemifacial paresis or hemifacial paresthesia, and in this case, when there is vertebro-basilar circulation, the legs tend to be weaker. Okay? So it tends to have lower limb emphasis. That's why you see some people, they get a stroke, and after the stroke, they walk like this. They have no movement at all in the upper extremity, but they're able to move some in the lower extremity. And some people after stroke, they are able to walk with cane, or even walker, because they have more strength in their upper extremity. So you see them, and then they will do. Right? Because they have more strength in the upper extremity. That is why it's extremely important to do physical assessment after stroke to kind of give the patient the right device. If somebody with a vertebro-basilar stroke survives, and you go and you give them a walker, or you give them okay, you know what I'm trying to say, right? If somebody is weaker in their upper extremity, right, and they're weaker in their upper extremity, what do they need? Do they need a walker or a wheelchair? They need a wheelchair, right? If somebody is weaker in their legs, what do they need? A walker, right? So you see, you kind of like walk very closely with the physical therapist to make sure you give the patient the right device, okay? But this is not physical therapy class. You got that, right? You know, you can never forget this. This figure here, you can never forget it. The vertebral arteries, just before they, as soon as they form the basilar, they give up the anterior inferior ICA, anterior inferior cerebellar artery. They form the basilar artery that supplies the pontine branches, and before they end as posterior cerebral, they give up the superior cerebellar arteries and then bifurcate into the posterior cerebral. That immediately establishes connection with the middle cerebral through the posterior communicating, right? Remember that. This is very important. It explains a lot in terms of how patient presents and what we tend to do when they have strokes. Okay? Now, there are some specific syndromes. They're so rare, and people just love talking about them. We've talked about this before, right? You remember this? We're talking about neurovascular evaluation. Yes, I did. I know I did. Okay. Do you remember Fisher 1.5?
Yeah.
Exactly. This is part of it. Okay. So the first one is the Wallenberg syndrome. Wallenberg is the name of the guy, but basically it's a lateral medullary syndrome. Okay. What Wallenberg syndrome is an ipsilateral cranial nerve deficit and a contralateral sensory motor deficit. Think about it. So these are all brain stem dysfunctions, right? Remember, cranial nerves don't cross, right? The corticospinal fibers are the ones that cross. So if somebody has a brainstem stroke, say a brainstem stroke, they will take out the cranial nerve on the side of the stroke, but they will take out the motor nerves on the opposite side, right? So what Wallenberg really described is a situation where you have loss of crude touch and temperature sensation on the ipsilateral side, right, of the face because of the involvement of the spinal trigeminal nucleus in the medulla, right? Remember I told you the trigeminal nucleus is the biggest nucleus in the brainstem. I wrote it here too. It spans the entire length of the brainstem. Even though the nerve itself comes out at the pons, its nucleus is extensive, right? So when you have an infarct, for instance, say in the pons, you will lose temperature, pain, sensations on that side of the face, but because you're going to trap the spinothalamic tract that are coming from the other side of the body, because they decussate as soon as they end at the spinal level, remember that? You will lose the same set of sensation on the opposite side. So you see somebody who cannot feel pain or crude touch or temperature on the right side of the face and on the left side of the body. That clinical combination, that is a reflection of brainstem infarct, is what is called Wallenberg syndrome, okay? And then similar situation in the midbrain is what is called Weber's syndrome. So they're all called crossed syndromes. Crossed syndromes in the sense that the cranial nerve deficit is on one side of the body and the sensory motor dysfunction is on the opposite side. So it's crossed, okay? Weber's is when you have an ipsilateral oculomotor lesion and contralateral hemiplegia, right? So somebody has a third nerve lesion palsy on the left and they have a right hemifacial paresis. That is a midbrain stroke that is taking out the oculomotor nerve nucleus on that side and taking out the corticospinal fibers that are going to the other side of the body, the opposite side of the body. Okay, again, you know I don't have light anymore, right? It's dead.
Oh man.
Yeah, no, but don't worry, we'll just make do. Okay, so again, this is just a picture of how this happens, right? You take out the nucleus and the fibers that are already decussated. I just put that there because I had that space. I didn't know what to do with it. I don't like empty spaces. Now let's talk about lateral pontine syndrome. This is your Fisher 1.5. You've seen this before, right? So somebody ends up with a pontine stroke right here. In that lesion on that left side, they will take out the facial nerve. Which nerve is it now? The sixth nerve, not the facial nerve. Is that the facial nerve? Abduction.
No.
They take out the abduction on that side, right? So they're not going to be able to move their arms to the left, right? At the same time, what is this fiber called? The one that is coming from the sixth nerve on the right side to the third nerve nucleus on the opposite side. What is that called? Exactly. At the same time, because it's in the pons, they will take out the MLF, the medial longitudinal fasciculus, right? So this sixth nerve nucleus is never going to be able to make any connection with the third nerve nucleus here, right? So basically, this eye on the left is not going to move at all. It will be completely paralyzed, right? And because the sixth nerve nucleus on the left is the root for the MLF to the right, you're going to lose the third nerve connection over here. So basically, the only muscle that this person will be able to move is the lateral rectus on the right side, because that is the only nucleus that is unaffected. And this was what Fisher was describing when he said when you have a pontine stroke that takes out your sixth nerve nucleus and the MLF on that side of the stroke, you will get complete paralysis of the eye on that side and half paralysis on the opposite side. And he called it 1.5. We talked about this before, right? Okay, it's seen in the pons, lateral, and it's called lateral pontine syndrome. But because it was Fisher that described it first, you will see it's also known as Fisher 1.5 syndrome. Okay, now let me not confuse you. The ocular manifestation is what is called Fisher syndrome. When that Fisher syndrome is now complicated by contralateral body weakness, it is now a lateral pontine syndrome. You got that? So when Fisher 1.5 syndrome coexists with a contralateral hemiplegia in a crossed syndrome, that is what lateral pontine syndrome is. Okay? So left conjugate original gaze palsy with the right internuclear of hemiplegia with the right hemiplegia. Right hemiplegia. Remember, the lesion is on the left, so but the body weakness is on the right, because you're taking out the corticospinal fibers that are on their way to decussate at the lower medulla. Remember that? Okay. Are we cool? Excellent. So how do you diagnose ischemic stroke? You do a CT scan. It matters now. Remember, in hemorrhagic stroke, you do non-contrast CT. That is what everybody says. Hemorrhagic stroke, non-contrast CT, because blood is a contrast, right? On CT scan, blood behaves like a contrast. But when you're thinking of an ischemic stroke, you're probably better off with an MRI. Okay? Look at it. If you have an arterial ischemic stroke and you do non-contrast, you will miss a lot, because it's only 16% sensitive. Although when it's positive, high specificity, 96%. But you miss almost 84% of the cases. Look at MRI. It's 83% sensitive and even more specific. So when you're talking about, when you're thinking that somebody has an ischemic stroke, what you want to do is an MRI. And there is a special MRI called CT or MRI venography when you're thinking that this could indeed be a venous stroke. Okay? So we're thinking it's a venous stroke because the patient is a sickler, or your patient has nephrotic syndrome, or any other causes of those venous strokes. You might want, let the radiologist know that I want a venography, CT or MRI venography, because I think this is a venous stroke. Okay? If you don't tell them, they will do a regular standard MRI or CT, and your result will be negative. Okay, because they're looking for a venous stroke. You pay attention to that venous side. And then there is also cerebral angiography that you can use to diagnose renal stroke. It gives you a corkscrew appearance. If you see the image, I don't have the image. Look at this MRI. Is the infarction on the right or left? Right, it's on your left, right? You understand that, right? This is, you see there, right?
Yeah.
Okay.
Dr. Martins, would the initial workup be CT scan first, non-contrast?
If you know for sure this is an ischemic stroke, you don't do. Okay, let me tell you. In the exam, you will do CT scan.
Right.
But everybody knows you're wasting time, you're wasting money, right? In practice, you do CT scan. In exam, it's MRI.
For the gold standard.
Ischemic, yes. Ischemic stroke, you're thinking ischemic stroke, you do MRI. Don't waste money doing CT scan. But what you will see in practice is everybody gets CT scan, and then when CT scan is negative, they now send for MRI. Okay. And the reason they do it is because MRI takes a little longer.
Right.
Patients, you don't have access to them. Many patients in strokes, they're not stable. You cannot put them in a box by themselves and leave them alone. So a CT scan allows you to kind of at least screen, make sure there is nothing dangerous, because ischemic hemorrhagic from the board, it looks like it's a very sufficiently distinct entities. In practice, it's not always like that, you know. So for the exam, MRI is what you want to do. In practice, you see that people do CT scans.
I remember like, I think it was emergency medicine where if you see stroke, the first thing you do is CT scan, and you want to have it done within 45 minutes.
What kind of stroke?
Ischemic.
What's wrong with that?
It was in ER, emergency medicine.
Kitty?
Yeah.
Okay, I'll talk to you about that.
Because you said you want to rule out that it's not a hemorrhagic stroke, so you don't promote TBA.
Isn't that what I just told you, that in practice, what you will see is, we talked about ischemic stroke and hemorrhagic stroke. Now when I'm talking about it on the board, in the room, in the classroom with you, they are very distinct. But sometimes in practice, you are not able to tell ischemic from hemorrhagic. Under those circumstances, we do a CT scan to rule out hemorrhagic because the management are different. But if you're clear, for instance, if a sickle cell disease patient come to you with a stroke, you will not do a CT scan. If you do a CT scan, you should be penalized, right? Because sickle cell disease patients don't get arterial occlusion, they get venous strokes, right? And why would you do a CT scan? So you see, the thing about it is this: in America, we know what is right, but the legal landscape is not in your favor as a provider. So people do everything to make sure that nobody can come back to sue them, right? And what that does is to raise the healthcare costs for the nation, okay? So what you see in practice is that, like I said, most people do CT scan, but what should you do? If you know for sure, or your probability for an ischemic stroke is really high, why are you doing CT scan? You don't do CT scan. The only time you do CT scan is hemorrhagic stroke. For sure, you do CT scan, non-contrast. Right, you got it?
Yeah.
I hope you're able to kind of like build it. She's telling you what they do in practice. I'm telling you why they do what they do in practice. So make sure the difference is clear. We're not saying different things. We're saying exactly the same thing. I'm giving you a little bit more information on why they do what they do. It is because you cannot always exclude hemorrhagic stroke that you do CT scan. If you are sure, especially in exams, the case is clearly an ischemic stroke, you don't do CT scan, you do MRI. Okay? In the field, it's a totally different question. And most of the time, the questions they ask you are straightforward questions. All right, so when you have a stroke, you never can tell how long that stroke is going to last, especially if you're seeing the patient very early. So a very strong differential diagnosis of a stroke is what is called transient ischemic attack. Okay? And what makes it a transient ischemic attack is complete resolution in 24 hours. Okay. You see, this is another area where CT scan is not good if you're thinking ischemic stroke. Because many times, if you do a CT scan will be negative, right? And you will say, okay, the patient doesn't have, for sure you'll be able to rule out hemorrhagic stroke, but then CT scan will never help you determine whether it's a mini stroke or a major stroke, because a negative CT scan does not mean that there is no infarction in the brain. You have to do MRI for that, right? That's another reason why you have to be careful what you do. So how does it present? It's known as mini stroke. Very important. It's brief, it's reversible, and it's a thromboembolic episodes, right? With neurologic dysfunction, but no infarction. The key word is that there is no infarction. So it's a dysfunction from which the patient recovers completely. So there is no infarction. He could present, yes?
So on the CT scan, within the 24 hours, would there be anything on MRI?
That's what I'm trying to say. In order for you to say the patient suffered a mini stroke, it is not the negative CT that you need. You need a negative MRI. Okay? You understand what I'm saying? Yeah. The patient can present with any number of symptoms, depending on which area of the brain is affected. They can present with weakness. It could even be of one arm. Numbness. It could be sudden blindness. And that sudden blindness is known as amaurosis fugax. Okay? It could be slurred speech. It could be speech difficulty. Bottom line is that it resolves within 24 hours with no evidence of tissue death, no evidence of infarction. Very important. Okay? Why do we care so much about it? Because if somebody has a TIA today, their risk for getting a major stroke within the next 30 days or so is very high. So if somebody has been having uncontrolled blood pressure for a long time and they suffer a TIA, that means a major stroke is around the corner. So that's what you want to see, that say, look, this is a sample of what could happen. Pay attention. And then there is this ABC, this called that the emergency room folks use to tell you about what your risk is for a stroke. When you present with a TIA, okay? It's a tool to improve the prediction of short-term stroke risk after TIA, okay? The truth of the matter is that would you really wait? Now let me ask you something. If somebody suffers a TIA, would you disregard counseling them because the ABCD score is low? You wouldn't, right? So these are those useless things people put in the literature just to put their name out there for something. It has no clinical utility, in my view. Okay. Now, if your patient was an attorney, they said, doctor, I just suffered a stroke. What is the probability that I will have a major stroke based on this episode? Send him a link to ABCD. Okay? So, how do you, I really like this thing over here because I think it tells you a good, I forgot where I got it from, but it was online. I kind of like it. I put this here because I like it. This is something Katie will talk to you guys about. Basically, how do you evaluate ischemic stroke? You want to look for potential causes for it. Okay, you do a CBC, what are you looking for? You're looking for polycythemia and hyperleukocytosis. You do comprehensive metabolic panel, the CMP. You're looking for blood sugar, blood lipids, especially if somebody you don't know before. You want to do diagnosis if somebody is a clot former, right? To rule out thrombophiliacs. want to make sure there is no arrhythmia, no underlying AFib or anything like that. I want to do an EKG to make sure there is no echocardiogram to make sure there is no endocarditis. I want to do a carotid duplex to make sure there is no carotid thromboembolism. And you want to do transcranial Doppler. When carotid duplex is negative, you may even want to do transcranial Doppler to rule out intracranial thromboembolism. Okay? And here is, this is not, this was actually from a hospital on their own protocol for triaging patients with strokes. And I think it was very, it tends to be, I like it. It's very detailed on what exactly you would expect to happen from the time the EMS calls that they are bringing somebody in, support ABC, give oxygen if needed. This is FYI. If you want to have an idea of how stroke assessment and evaluation is done from the field to the emergency room, you just follow this, but it's nothing more than I've already told you. In terms of following it up, we can go through it. But yeah, let's go through it. Okay, so identify signs and symptoms of possible stroke, activate emergency response. Call 911, right? That's the purpose of FAST, right? Then they get there, the EMS folks get there, they evaluate the patient. If the patient needs resuscitation, they do the ABC, airway, breathing and circulation, give oxygen if needed, right? They right there, they perform the pre-hospital stroke assessment. Basically, is this a stroke or is it not a stroke, right? EMS will tell you that, okay? And then they give information to the calling to the stroke center to let them know how bad this stroke is, right? Okay. Now the truth of the matter is that does the EMS people know whether this is a stroke or a TIA? They don't. But they're going to assume the worst, right? They're going to treat it like a stroke until it is proven that it was a TIA, right? And then they check glucose if possible, they alert the hospital. Once the patient gets in there, again, the hospital emergency room doctors now take it over. They do exactly the same thing, resuscitate the patient, vital signs, provide oxygen if the patient is hypoxemic, provide more stable IV access. They check glucose, they treat as indicated. They do their neurological screening, right? They activate the stroke team. There is always a stroke team. And the only time they will do that is if they're thinking the patient is eligible for thrombolytics, right? You're going to give a clot buster. The stroke team usually will do that, right? And then they come and they do their assessment, review the patient history, time up. They do a CT scan. You see the purpose of the CT scan is to rule out hemorrhage. You can see that, right? So if there is no hemorrhage, then you're sure that this could indeed be an ischemic stroke. Then they begin to work the patient out for potential thrombolytics. If there is hemorrhage, it's a totally different story altogether, right? Patient remains in candidate for thrombolytics, they give thrombolytics, yada, yada, yada. All of that, 3 hours is important. The patient must arrive in the ER early enough for all these things to take place within 3 hours. Okay? Why do you think the 3 hours thing is so key?
More damage to the brain.
Thank you. If there is a major blood vessel in that core area and there is infarction, and the vascular wall is already implicated in the necrosis, and you give a thrombolytic, what will happen? You will convert an ischemic stroke into hemorrhagic stroke, and you'll kill the patient right there. So that's why it takes the stroke team to kind of take a good look. It's not one person decision, it's a team. So that when the decision is made to give thrombolytics, everybody agrees that this will help this patient. Because if you're not careful, you can actually kill it. All right. NIH came up with the stroke severities scale. That is what it is. It's there.
Here it is.
I don't think anybody would ever test you on this. Did Katie talk about this?
They would mention the same thing, just
Yeah.
doesn't exist.
You know why all these scales are being put out there? Because there's a lot of research and they look for a way to standardize patients to see whether any particular medication works. So you want to make sure that all the patients that are in the trial are equally sick. So if you say, oh, the medication helped them, it will help everybody. Because investigators that are paid by these pharmaceutical companies, they can recruit lightly ill people that would otherwise recover. For instance, think about it. If you recruit a bunch of TIAs and strokes, right? And say, okay, this holy water will make sure everybody recovers, right? But you specifically go and you recruit TIAs. You will come up and publish a result that says your holy water worked 100% of the time. So if you have a stroke, call this number. Get your holy water right now. But the study is flawed. You put all these TIAs there. Without your holy water, they would have recovered anyway, right? So you see, in order to make sure that everybody that is in a study is equally sick, we have to look for a way to standardize them. So this is what one of the purposes for the NIH severity stroke. It's not for you to go there, okay, how severe is the stroke? A stroke is a stroke, okay? And patients will tell you how severe it is because the brain swelling that comes afterwards depends on the extent of the stroke, okay? So I give you these things. It's not for you to go and start memorizing tables. This is just FYI, okay? You know it exists, okay? How do you manage it? Like I said, ischemic stroke, there's occlusion, patient is in the emergency room in the hospital under 3 hours. You want to give thrombolytics, and usually you give it intravenously. Okay? If your patient misses the 3-hour window, but you still believe you can do everything you need to do between 3 and 4.5 hours, they can still get thrombolytics. But that thrombolytic has to be given into the occluded artery. Because when it is more than 3 hours, you can't afford to give an IV. Because IV will go to more area than you need. And your probability of converting an ischemic stroke to a hemorrhagic stroke is a lot higher. But if you put it in the occluded artery itself, it's a little bit safer, right? So if the patient is early, under 3 hours, his IV is okay. More than 3 hours, but under 4.5 hours, they can still get thrombolytics, but it's got to be intraarterial. And if they're eligible for thrombectomy, where you can actually dislodge the clot and cut it out, that's what you should do. Venous clots give anticoagulants. That is very important. Okay? If somebody has ischemic stroke of venous origin, you give anticoagulant, not thrombolytics. Extremely important. And generally speaking, for anticoagulation, you start with Lovenox, low molecular weight heparin, and you start Coumadin at the same time. So once your Coumadin is therapeutic, you discontinue your Lovenox. You know that, right? Right?
Yes.
Good. Now, depending on the extent of the ischemic stroke, the surrounding tissue will exhibit inflammation, right? It's just like humans. If a human being is dying in the presence of other human beings, those other human beings agitate. They want to do something. They want to rescue. There is chaos, right? The same way, when a group of cells are dying in any part of the body, the surrounding cells that are alive, they always go into inflammation in response to that dying cell. So when the infarction is a small area of infarction, you get inflammation of the surrounding tissue to the infarction, and the whole brain may not be affected, but those regional cells that are still alive will show evidence of inflammation. But think about it. If it was a major stroke, say a major MCA infarct that took out the entire middle cerebral territory, the whole brain will swell. When the whole brain swells and the skull does not stretch, you now have to deal with the intracranial hypertension. And we have very limited options to deal with intracranial hypertension. We give osmotherapy. We'll talk about this in nephrology on Wednesday, right? Not this Wednesday, the following Wednesday, right? Okay, we'll talk about this. So basically, mannitol is a sugar. The body does not metabolize it. It goes through the circulation, and it has some serious osmolar effect. So what it does is it pulls water from the intracellular space into the intravascular space, right? So that is how we deal with it. We use it for intracranial hypertension. So the idea is to create this hyperosmolality in the circulation to draw water out of the brain, to shrink the brain from and relieve the inflammatory edema. You got that? And sometimes we do lumbar puncture. Very dangerous, by the way, but you will do it. Because in this case, you want to relieve the pressure by taking out some CSF. If you're not careful, the patient can coma and go into respiratory arrest. So that's why we do tiny needles and take the CSF. And usually it's done with intracranial pressure monitors. Okay? And then sometimes you may even have to do external ventricular drains that are connected to the lumbar puncture, or you do internal ventricular drain. These are drains that drain the CSF out of the brain into cavities on the outside and cavities on the inside. You have the lumboperitoneal shunt, the ventricular peritoneal shunt, or ventricular atrial shunt. All these shunts to relieve the pressure. These are all devices. And then when push comes to shove, you know what we do? We call in the neurosurgeons and they'll take out a portion of the skull. Okay, so they'll just go and cut a hole, a big hole in the skull, right? So the idea is to allow the brain to swell out of the skull. And as they treat the patient, the brain shrinks. They now put a titanium plate and cover the hole they've created in that process called a decompressive craniectomy. You've seen that before. You've seen people with plate in their skull before? Do you know anyone? Have you seen it? Okay. I've seen quite a couple. All right. So this is what you do. There was a study one time that tried to suggest that maybe we should use steroids. They don't help. Okay, that's the bottom line. Okay, steroids do not help inflammatory edema in strokes or any other situation. All right. I told you that you can take out the management of intracranial hypertension requires intracranial pressure monitoring devices. So these are those devices. This right here is in the subarachnoid space, connected to the monitor at the head level. So you use this to monitor the pressure of the intracranial pressure as you take out CSF. These are very complicated setups, okay? Neuro ICUs and all these places where you see this. So generally speaking, if you have the opportunity to be around somebody that is carrying an intracranial monitor, the best person to learn from is the nurse. Okay, just call them and they're usually eager to teach you something. Okay? And they'll tell you how everything works. Okay? When do you need intracranial monitors for everybody with intracranial hypertension? No. The only time you need it is if your CT is abnormal, with hematoma, contusion, edema, herniation, compressed basal systems. When there is structural changes in the brain as a result of the intracranial hypertension, you should think seriously of putting a monitor. Okay? When there are no structural changes, so your CT scan is normal, but your patient is over the age of 40, they have some serious clinical manifestations like motor posturing, or systolic blood pressure is less than 90. That is a problem. Because when systolic blood pressure is less than 90, you need to improve the systemic pressure and not compromise the intracranial pressure at the same time. So that is a dangerous gamble. You need to have a CVP line, an ICP line, and now gauge, maintain the blood pressure just enough to keep the intracranial pressure at a minimum. Very complicated patient management. This is not something I can even begin to tell you a little bit of in this classroom. And the closest I've come to this type of management was when I was patient escort at UCLA. And I used to carry these patients for their test. You go in the room, it takes hours just to unplug them for transport. So if you're interested in that kind of high intensity medicine, it's fun, but it becomes tiring very quickly. When would you not give anybody thrombolytics, even if they arrive within 3 hours? Well, if they arrive within 3 hours, you will give it. But if they arrive without 4.5 hours, you will not give it. Or they cannot tell you when it started. Okay? When your patient is less than 18 or over the age of 80, be careful. It's not an absolute contraindication, but you have to kind of like go case by case. Okay? Again, some will use stroke severity scale to decide whether or not they will give thrombolytics. You see that evidence of intracranial hemorrhage? That's why you do the screening CT scan. Okay. Seizure at the onset of stroke. If your patient had a seizure at the onset of stroke, what does that tell you? Loss.
You had a seizure at the onset of the stroke.
So anybody tell me what a seizure means? Why does it matter that a patient with the onset of stroke had a seizure? Thank you. That means there is a possibility of a brain tumor, right? And the stroke may have been an hemorrhage from the tumor itself. If we give that kind of patient thrombolytics, you will kill them. Okay? Very important. Okay? Symptoms indicating subarachnoid hemorrhage, even if CT is normal. You see that? So if somebody had a normal CT, but they presented with neck stiffness, positive Koenig and Brudzinski, well, positive Koenig and Brudzinski tells me this is, neck stiffness tells me there's subarachnoid hemorrhage. Even if the CT scan says it's negative, I'm going to treat that patient as hemorrhagic stroke. Okay? And you will not give them thrombolytics. Okay, general increase in bleeding risk. Somebody on oral anticoagulation, like somebody has AFib and they're already taking Coumadin, now they develop a stroke. Would you give them thrombolytics? Of course you wouldn't, right? Exactly. Or somebody has an alcoholic with portal hypertension, history of upper GI bleed, now has a stroke. Would you give him thrombolytics? Of course you wouldn't. Especially if those are like recent things, right? And then somebody has had a major surgery, that's a relative contraindication by the way. Major surgery within the last 3 months, okay? Increased risk of intracranial bleeding as felt by some of these examples over here. So really, the contraindications are listed here by major headings, and over here are just descriptions of what that really means. You got that? Okay. Generally speaking, nobody tests you on this thing because these are not written in stones. These are relative. Sometimes a team decides, even in the presence of a contraindication, whether or not to move forward or not move forward. Okay? I know you don't have this slide. But do you have anything close to it? What is your next slide?
Prevention of ischemic strokes.
Okay, fine. Let's talk about this quickly. In an acute setting with ischemic stroke, we don't mess with blood pressure. For the reasons I already explained to you, right? What do you expect the cerebral tissue to do, the surrounding cerebral tissue to do when there is a stroke? They will have inflammation, they will swell. Intracranial hypertension limits intracranial perfusion, right? In order for blood to flow to the brain, the pressure in the system must be greater than the pressure in the brain. So if somebody develops intracranial hypertension, the autonomic nervous system is wired to raise the systemic blood pressure. It happens all the time. It's called Cushing's response. Okay? Whenever there's intracranial hypertension, the systemic blood pressure will go up. There's a reason for it, because blood flows according to pressure gradients. So when there is intracranial hypertension, the pressure gradient for cerebral perfusion is kind of steep. So you need more pressure on the systemic side to push blood into the brain. So generally speaking, we don't mess with blood pressure in acute stroke. We allow systolic blood pressure to go as high as 220 without treating it. I tell you, one of the most interesting things I've seen was when I was on internal medicine consult service across the street, right? And they will help this stroke patient. And most of the time with stroke patients, the neurologists they are the primary care team. And then they will drop a consult for us to help them with blood pressure management. And then you go there, and blood pressure will be like 240 over 120. And they will be like, no, you can't treat it. I'm like, why did you drop the consult? If I cannot control the blood pressure, why are you bringing me here? Right? We all know the guidelines, right? It's 220 is the cutoff. This person's blood pressure is 240. You know why they won't let us lower the blood pressure? Because we cannot guarantee where our dose of antihypertensive will lower the blood pressure to. They cannot afford for that patient to have a 200 systolic in the acute phase. So unless we can guarantee them that we'll lower it only to 220, they will let us do it. But there's no way I can guarantee you how your patient will respond to labetalol. I'm not God, right? So it's a very interesting. I just put this here. The bottom line that I need to take home is there is a strategy of permissive hypertension involved in the management of ischemic stroke. We allow the blood pressure to rise as high as it needs to rise to maintain blood flow to the brain within the context of intracranial hypertension, and we don't mess with it. And the guidelines say you begin to try to control it when systolic is more than 220 or diastolic is more than 140. And these are some of the agents that we use. We don't use everything. Sodium nitroprusside is good. Labetalol is good, right? The reason you have to be very careful with other medications, especially IV medications, because some of them actually increase the cerebral edema. Okay, so it's extremely important that you pay attention to the medications that I mentioned here. Nitroprusside, labetalol. Okay? I'm sure Kerry talked a little bit more about that. So what are the numbers you must be aware of? Mean of 130, diastolic 140, systolic 220. And if thrombolytic has been given, you definitely want to keep it under 185. Okay? Why do you think there's a difference between the blood pressure you're going to tolerate with or without thrombolytics? Without the risk of bleeding is higher with thrombolytics, right? So you don't want people to have 220 systolic with thrombolytics on board. So you want to make you want the blood pressure to go above 185 if they have received thrombolytics to minimize the risk of stroke. Okay. Do you have this slide?
No.
Okay. Yeah, I guess I updated it. And I forgot to update it and now. I resend it. Generally speaking, after a stroke, people have stroke-related symptoms. There is nothing you can do about those symptoms, but you can control them. Okay? And some are worth mentioning. Somnolence. In patients, which part of the brain would have to be involved for a patient to suffer somnolence after a stroke? Thank you. When you have brainstem stroke and you take out the reticular activating system, even if the patient recovers, remember, when you take out brain tissue, you don't get brain tissue back. You get sclerosis. Fibrous tissue is what you get. So if you get brainstem infarct and you take out the reticular activating system, the patient recovers from the stroke, all right, but they've lost part of the reticular activating system. They will be sleepy most of the time, right? So how do you control that? You give them stimulants. Methylphenidate, amphetamine. Yeah. You have to keep the patient awake. Okay? You need to know this because you're going to be the one needing this. Many, many times your patient would have suffered a stroke and the acute care team will discharge them. They say, follow up with your PCP. Then your patient's children will come to you. He sleeps all day, he sleeps all night. But you have to wake him up to eat. That is an indication for you to give the man some amphetamine. And then there is pseudobulbar affect. Remember what that is? Where else do you see that? Pseudobulbar affect. Huh? Dementia, right? It's basically what it is. It's an emotional incontinence. Okay, so patient with pseudobulbar affect, it's called PBA. They have sudden uncontrollable outbursts of crying and laughter. Not together. So they just come in and say, hi mom. Hi, Andrew's here. Mom, what? Why are you crying? And then she can't tell you why she's crying. Then the next week, you're on your way home from work, you say, let me see my mom. Say, hi mom. Say, hey, how are you? I'm not saying. I was just here today, right? Right. So you see this emotional incontinence is what pseudobulbar affect is. It responds very well to SSRIs. Okay? Selective serotonin receptors inhibitors like citalopram, it will help. Of course, remember we talked about central sleep apnea, right? Hello? In pulmonology, sleep apnea,
Yes.
right? Okay. Obstructive and central, right?
Yeah.
How do you treat that? CPAP, BiPAP, pressure support, or diaphragmatic pacing? We talked about that. You know that. I don't have to repeat myself, right? Do I?
No.
Thank you. Again, I had this space here. I didn't know what I had to do with it. I put a picture here for you. Right? What? Initial injury, post-stroke depression, stroke recovery, delay recovery and cause a second stroke for response prompted to antidepressant. Okay, yeah, I remember that. So the idea, why do we worry about depression after stroke? Because after stroke, right, somebody can become depressed and now stop taking their medicine. And you know what is unfortunate is sometimes patients that get stroke are the ones that took you serious. They've done everything that they needed to do. They took their medication, they ate right, they exercised, and then they get a stroke. They are the most difficult post-stroke patient because they go into severe depression. Like, Dr. Martins, I did all this. Look at me. And you as a care provider, you just want to cry. Yeah, it's true. You did everything. But you can't lay down and die. You're still breathing. For as long as you live, you must take care of yourself. As long as she's still breathing, you have to keep doing it. Because if you don't, the next one will be worse than what you just went through. You know? And that is where sometimes life becomes so complicated. I have patients that don't care. They smoke anything, they drink anything, they do whatever they want to do. And like, doctor, I only got this one life to live. And they get away with everything. And then you get these other patients that are so afraid of stroke and they do everything. Once you tell them, you are treated for cancer, oh, they go get the screening. You are treated for diabetes, oh, they run to get the blood sugar. They cut out everything because they want normal blood sugar. They are the ones that get sick. What you fear the most in life is what ends up befalling you. It's so crazy. You know? So when that happens, patients tend to like give up, right? And then that's when you really need to treat them. Post-stroke depression is very common. You need to treat them and help them over the hump. That's the point of this little thing I put there. All right, prevention of stroke. Yeah, if you can, you should. You all know the difference between primary and secondary prevention? The primary prevention is preventing the morbidity itself. Secondary is limiting the morbidity, right? So if I control your blood pressure and your blood sugar and I prevent stroke, that is primary prevention, right? If I give you antidepressant and citalopram to prevent you from getting second stroke, that is secondary prevention. Remember that, right? Okay, we got that. So basically everything you need to know, all this you already know. Healthy eating, happy, active living, anticoagulation for atrial fibrillation, blood pressure control. And I gave you some things here based on studies, right? 10/5 reduction in blood pressure will cause stroke risk by 40%. That's important. Lipid control, blood sugar control. Unfortunately, blood sugar control does not influence your stroke risk. Okay. Whether you pay attention to blood sugar or not does not mean you're going to be less prone to stroke. Studies say it doesn't. But does that mean you can watch diabetes go uncontrolled and say, oh, no, don't worry about it, you're not going to get a stroke? No. What about heart attack? How about kidney damage? You may not get a stroke. You know, that's why sometimes I find some studies stupid. Why are we looking at stroke risk in controlled diabetics? Is that the way patients come? I have very few patients that have only diabetes. Most of my patients have diabetes, hypertension, cholesterol, arthritis, at least. All those four you find in more than half of my patients. So what good are you doing me after you've gotten millions of dollars from the federal government to tell me that, oh, by the way, diabetes control does not influence stroke risk? What does that mean? For me, in practice, what does that mean? Does that mean I can ignore uncontrolled diabetes because my patient will die of stroke? Why did we even give you that money to do that study? Okay, so secondary prevention, you can use single agent, antiplatelet, aspirin, taclopidine, clopidogrel. I put these things here because many times you will start aspirin, but you're less likely to be the one to start taclopidine and Plavix. Others will start it, and they will send the patient to you. You need to know that Plavix can cause thrombotic thrombocytopenic purpura. You know how deadly that is, right? And taclopidine can cause agranulocytosis. So you must do the CBC fairly frequently, every 3 to 6 months. Okay? And then this is hormonal replacement therapy, and Dr. Nelson put all kind of studies. I look at her lecture slides. She put all kind of very confusing slides out there. What I need you to know is that estrogen-based hormonal replacement therapy and selective receptor modulators like tamoxifen, they've all been associated with increased risk for stroke. Okay, so there's no cutting corners about it. That's a fact. Okay. Oral contraceptives are harmful in women with additional stroke risk. So if a woman is taking birth control pills and they're smoking and they're overweight, they're going to get hurt. Okay. Although you can mitigate the risk by giving them lower estrogen pills, but the truth is, do we really know what lower estrogen means? If I'm going to give a lean woman estrogen and an obese woman estrogen, what does lower dose mean? When the fat cells can convert estradiol, what is that? Estradiol and estrone is converted interchangeably within fatty tissue, right? So what does low dose mean? Are you trying to understand? Are you with me? The studies say low dose estrogen can lower stroke risk. My question is, what does low dose mean? Because the dose of how estrogen behaves in women depends on the amount of adipose tissue they carry. So what does low dose mean? And low dose has not been defined based on BMIs, which is important. You understand what I'm saying to you? So what I'm saying to you is, I personally, when my patients have strokes, I go get IUD or birth control. There is no way around it. No. Because I don't know how to tell you what is safe. If I cannot tell you what is safe, I abandon the entire medication altogether. Okay? Because we say, above all, do no. All right. Good. Any questions? Any questions? No, everything I said is clear. Anything contradictory from what I've said and what you heard in other classes? Everything is in sync. All right, so I give you 5 minutes break, and then we'll start back at 1:10. So Christian, you got your break, man.
Yeah, I need to pee. I don't want to miss it.
Yes.
Ali,
Yes.
when is the Lala event?
Lala?
Lala.
I do not know.
Okay.
Um,
Okay. Doyen will know.
Hey, do you know when Lala is?
Doyen, when is the Lala event?
This weekend, I already told.
This weekend? Oh, I'll be in New York.
I already told you.
Okay. Yeah.
Next month.
Next month, let me know. I'll make my clinic adjustment so I can be there at least for 2 till the end of it.
What are you doing in New York?
In the summer, right? I get invited to preach. Hey, what's going on, man?
Not much. Trying to stay alive.
Is ischemic stroke, right? 90% of the strokes. Now let's talk about hemorrhagic strokes. So hemorrhagic strokes, they come mostly from aneurysms, but it can also come from ruptured AV malformations. They can come from cerebral amyloid. You know we talked about amyloidosis, right?
Yes.
Amyloidosis is formation of this abnormal protein, usually as a result of chronic persistent inflammation. As part of amyloidosis, you can have amyloid deposition in the vascular wall. And when you begin to deposit amyloid protein in vascular wall, you alter the structure and the function of those blood vessels. And that is what is called cerebral amyloid angiopathy. Then you can also have drug-induced bleeding, like somebody on anticoagulation, bleeding diastasis. Then you have what we talked about earlier, hemorrhagic transformation of the prior ischemic stroke, usually within the acute setting. But all of these are causes of hemorrhagic strokes, but most of the hemorrhagic strokes are going to come either from congenital Berry's aneurysm or what is called the Charcot-Bouchard aneurysms. Berry's aneurysm are like berries. That's why they're called berry aneurysm. They usually at the base of the brain. They are usually formed in the circle of Willis. Okay? They bleed, they rupture directly into the subarachnoid space. Charcot-Bouchard, also known as miliary aneurysms, are actually microaneurysms. Berry's aneurysms are macro, they are berry-sized aneurysms. Charcot-Bouchard are microaneurysms of the small single penetrating branches of the cerebral arteries. So the same arteries that give you lacuna infarct are the ones that give you Charcot-Bouchard and microaneurysms. Charcot-Bouchard aneurysms are found only in patients with chronic uncontrolled hypertension. And Charcot-Bouchard aneurysms don't cause subarachnoid hemorrhage, they cause intracerebral hemorrhage. But there is a trick right there. If somebody with a blood pressure, say 220/140, ruptures a Charcot-Bouchard aneurysm, they will get intracerebral hemorrhage. But because of the pressure, that blood in the brain can dissect the brain tissue into the subarachnoid space. And you end up with both intracerebral and subarachnoid. Okay, so even though typically, classically, we say Charcot-Bouchard causes intracerebral and Berry's aneurysm causes subarachnoid hemorrhages, Charcot-Bouchard sometimes can dissect brain tissue into the subarachnoid space when the rupture occurs under very high pressure. You got that? Okay. And this is what it looks like, right? Intracerebral, subarachnoid. Subarachnoid, intracerebral. Artery within the brain, ruptured aneurysm. Aneurysm, circular aneurysm. Now, there is something you need to know about hemorrhagic stroke. Hemorrhagic strokes, they make up about 10% of strokes, but they account for 40% of stroke mortality. So if I tell you, if you heard that somebody suffered a stroke and died, they are more likely to have had a hemorrhagic stroke than ischemic, which is the more common stroke. You got that? How does it present? Hemorrhagic strokes present in two ways. Oh, by the way, did I tell you? Let me tell you now, because I don't know when I'll have an opportunity to tell you that I remember. For my lectures, for my slides, all you really have to do is listen carefully and take good notes. There is no textbook on the planet that will give you everything I give you in my lecture. None. Because what I give you in my lecture is not just textbook stuff. It's textbook experience and my way of pitching it to make sure you understand it very well. So you'll be wasting a lot of time if you try to review any textbook on a subject that I teach. If you must do that, then let that textbook be harassing. If that textbook is not harassing, you're wasting your time. If you do it, you realize. If you do it and you learn something new, I'd like to know about it. I just think I should tell you because a lot of people go and they read all this other stuff online and they come to me with all kind of questions, complicated matters. I know what I'm talking about. Do yourself a favor. I'm not discouraging you from extra reading. If I mention something slightly in my lecture and you want to know more about it, go specifically to look for that thing. But in terms of what you really need to know in the overall scheme of things, I do my best to give you all I know you need to know in the easiest and the simplest way you need to know it. Okay? So, clinical manifestations of hemorrhagic strokes, right? There are two groups. There is a common manifestation you will see in everybody with a bleed. And there are specific manifestations that you see only depending on whether it's a subarachnoid or intracerebral. Everybody with hemorrhagic stroke will tell you they have a headache. They have evidence of intracranial hypertension. Remember that intracranial hypertension in ischemic stroke is a reactive process, whereas, in other words, it's a secondary process. Intracranial hypertension in hemorrhagic stroke is a primary process. That is why vomiting is not common in ischemic stroke, but it's common in hemorrhagic stroke. Okay? Are the initial manifestation. And then I told you about Cushing's triad. Whenever there is intracranial hypertension, the autonomic nervous system does something crazy. It raises the arterial pressure, it slows down the heart rate. The idea is to maintain cerebral perfusion in the presence of intracranial hypertension. And breathing becomes irregular. The reason breathing becomes irregular is because the respiratory centers, they try to modulate the PCO2 levels. Since PCO2 is what forms bicarbonate, right? And bicarbonate is the major anion in the CSF. One way you can also regulate CSF volume is by regulating the amount of bicarbonate in it, right? That is why you give Diamox to pseudotumor cerebri, right? Okay. So breathing all of this, and then third nerve palsy. Remember surgical third we talked about? Good. And then what is interesting is that sometimes the subarachnoid blood can dissect into the optic nerve sheath. And when it goes into the optic nerve sheath, you get all the way to the eye. And when you do fundoscopy, you see blood in the fundus. Remember when you look at the retina where the optic nerve exits, right there, you see blood. And that blood is coming from the subarachnoid space, dissecting through this nerve covering. That is called subhaloid or vitreous hemorrhage. And when you see it, it's called Terson syndrome. Okay, Terson syndrome. And of course, when intracranial hypertension is severe enough, the patient will lose consciousness. Okay? And again, you have the sympathetic activation that gives you the sympathetic surge, elevated blood pressure, sweating, and all that. This you will find in everybody with hemorrhagic stroke. Okay? And it's basically headache, intracranial hypertension, and sympathetic activation. Everything here, vomiting, Cushing's triad, third nerve palsy, Terson sign, they're all signs of intracranial hypertension. Okay? So if I could flip this and say signs and common signs and symptoms of hemorrhagic stroke. Another symptom, I'll put vomiting. Another signs, I'll put hypertension, bradycardia, irregular breathing, third nerve palsy, Terson sign, altered level of consciousness. Okay? You can arrange it any way you want. Now, if your patient has a subarachnoid hemorrhage, they will have neck pain, neck stiffness, they may have seizures because blood is irritating to the brain. Okay? They have positive Kranig's and Brzezinski's. And if it is an intracerebral hemorrhage, you will get neurological deficit. Okay? So this you get with Charcot-Bouchard. This you get with subarachnoid hemorrhage. Okay? You with me? See, this is a non-contrast CT scan. Blood itself behaves like a contrast on CT. You don't need anybody to tell you there is something strange here. That is blood. That is the way intracerebral hemorrhage looks. Okay? Look at the CT scan non-contrast. 89% sensitive, 100% specific. Non-contrast CT is more sensitive than MRI for hemorrhagic stroke. We're talking 89% versus 81%. Okay, this fact is so important. It will be tested every single time. And then look at subarachnoid hemorrhage, right? All those white lines. Because once you bleed into the subarachnoid space, you contaminate the CSF. Right? And wherever CSF is, that blood gets there. And depending on which level the CT scan is taken from, you can see blood in the basal cistern, blood in the sylvian fissure, you can see blood in the posterior horn, you can see blood in the salsa. Okay? Blood, blood, blood everywhere.
So for hemorrhagic strokes, CT's first
CT.
and better than MRI.
Yes.
Okay. And
Yes.
for ischemic MRI is more effective.
Exactly. Okay. Whenever this is suspected, I know what is interesting. It is not every time that CT scan. Remember, CT scan is sensitive 89% of the time, right? So that means you still miss 10%, right? So it's not all the time that non-contrast CT is positive with hemorrhagic stroke. There are times patients will come to you with clear signs of subarachnoid hemorrhage or hemorrhagic stroke. My neck hurts, they have neck stiffness, they have positive conics and skin, and you do CT scan and it's negative. But you believe strongly that this person is bleeding. Whenever that is the case, you have to do a lumbar puncture. Okay? So lumbar puncture is indicated in all suspected cases of subarachnoid hemorrhage with negative non-contrast CT. Why do we do lumbar puncture? Because we are looking for xanthochromia. That's why we do lumbar puncture. Differentiate traumatic time from subarachnoid hemorrhage by xanthochromia. Now let's talk about xanthochromia. Xanthochromia is present within 2 to 4 hours of subarachnoid hemorrhage, and it persists for over 2 weeks. But in order for you to have a positive xanthochromia, the patient must have bled at least 200,000 RBCs into every liter of cerebrospinal fluid. So let me give you an example. If, and this is a very weird example, Richard Buckard aneurysms are microaneurysms. If instead of bleeding into the brain, it leaks somehow, and that leak gets into the subarachnoid space, that would be microbleed, right? You will not find 200,000 red cells in that kind of a bleed, right? So xanthochromia might even be absent in the presence of that kind of a bleed. So what I'm saying to you? What I'm saying to you is, yes, xanthochromia is good. It will help you identify subarachnoid hemorrhage, even if it has happened after 2 weeks. But in order for you to have xanthochromia, you must have bled at least 200,000 red cells into every liter of CSF. Okay? But if you find it, look at it, 100% sensitivity, 91% specificity. Now, what is this yellowing that we call Have you seen CSF before? It's like water, right? When you see a yellowish tinge to it, that's what we call xanthochromia. How does it come? Xanthochromia refers to the pale pink to yellow color in the supernatant centrifuge CSF. It is pink, orange, or yellow owing to red blood cells lysis and hemoglobin breakdown. Pale pink to orange xanthochromia is observed on lumbar puncture performed 2 to 4 hours after the onset. It turns yellow because the hemoglobin ultimately gets converted to bilirubin usually after 12 hours of the subarachnoid bleed. So xanthochromia, yellowing of the CSF, is the ultimate, but it could be anywhere from pink to orange before it turns yellow, depending on when you're doing it. So if your patient comes to you, or a kid goes out, say on camping trip, right, and you get a call from the school that the kid developed a headache, vomiting, his neck was stiff, they took him to the local hospital, they just observed him over the weekend and they sent him home, and the CT scan was negative, and nobody could tell you exactly what was wrong with the child. You tell them to send the kid home, you go and do a lumbar puncture. If it was a subarachnoid hemorrhage that the kid had, CSF shows xanthochromia. Okay? Again, hemorrhagic stroke and intracranial hemorrhages are two different things. Okay? We talked about this already, epidural and subdural hematomas, right? These are bleeds outside of the brain. They are not strokes. Okay? So it's extremely important. I don't want you to get confused. Hemorrhagic strokes are bleeding within the brain and its covering. These intracranial hemorrhages, on the other hand, epidural and subdural, are outside of the brain. They are between the brain and the skull. Okay? And we talked about this already. I talked about the lucid interval. Remember that? Okay. I mentioned here to make sure you don't get confused. Okay. These are not strokes. General management of hemorrhagic stroke, of course, you admit the patient, you take a good history, you do the Glasgow Coma Scale and pupillary assessment, you order blood tests, non-contrast CT. See, everybody keep writing non-contrast CT. If they were on anticoagulation, you reverse it. Okay? Invariably, they have to go to surgery and all kind of options, right? General anesthesia, borehole, craniotomy. The idea is, in many hemorrhagic stroke, you want to relieve the intracranial hypertension because of the bleeding. You want to stop the bleeding, control the pressure. That's all there is to it. And different hospitals have different protocols, right? It's one of those. I found it elaborate and interesting, right? Pre-operative, post-operative management. This is not what you learn in classroom. You just need to know that when you have hemorrhagic stroke, you have a problem. You're going to control the pressure, and you're going to stop the bleed. And you do everything else like everything else. You admit the patient, you screen them, you work them up, and all that. You know what is interesting? Hemorrhagic stroke has some very unique complications that you need to be aware of. Ischemic stroke, not as much, but hemorrhagic stroke, because of the severe nature of it and the lethality of it, it is like the body calls 911 every time. It is perceived as life-threatening. Hemorrhagic stroke are perceived as life-threatening in the body whenever they happen. Sorry? Okay? So there are some things you must watch out for. The 4 complications are Cushing ulcers, cerebral vasospasm, aneurysmal rebleed, and epileptic seizures. These are the 4 complications. they will follow a lot of patients with hemorrhagic stroke. Cushing's ulcers are gastric ulceration associated with elevated intracranial hypertension. You know about Collins ulcer, right? You find it in extensive burns patients due to gastric acid hypersecretion. The equivalent of Collins in intracranial hypertension is called Cushing's ulcer. Why do we worry about them? Because they happen usually in the greater curvature and they get free perforation very quickly. So you'll be focusing on the brain and your patient will develop peritonitis and go into septic shock. What happens when you go into septic shock? Blood pressure drops, the brain dies, you might lose your patient too. See why this is so important. So generally speaking, when somebody has developed hemorrhagic stroke, we don't wait for them to complain of pain. Routine admission orders, you must give them proton pump inhibitors, H2 blockers. Cimetidine works great. You don't wait for the patient to complain. Part of admission orders, standard is H2 blockers, right? And then epileptic seizure, like I said, blood is irritant. Epileptic seizures increase cerebral metabolic rate and intracranial pressure. It makes the intracranial hypertension worse. So you don't wait for them to seize. All hemorrhagic stroke patients get put on dilantin. It's seizure prophylaxis. Okay? Cerebral vasospasm. Again, blood is irritant. The only blood the brain wants to see is the blood flowing within blood vessels. Whenever you expose naked brain cells to blood, you irritate them. Okay. So cerebral vasospasm is very common. I know what is interesting. The irritation of the blood is one. Cerebral vasospasm is another attempt of the body to limit blood flow to the brain when there is intracranial hypertension. So the brain is trying to protect itself. But what it ends up doing is compromising blood supply to other part of the brain, right? So the purpose of the vasoconstriction is to limit blood flow and limit the rise in intracranial pressure. But the trade-off is that you're compromising function. So we tend to fight that cerebral vasoconstriction by using a specific calcium channel blocker known as nimodipine. It's the only one for over 20 years that has proven, it's a calcium channel blocker that has proven and is still used. And what is interesting, I'm surprised that nobody has done any trial to see, or equivalent trial, to see if there are alternatives to nimodipine. So both in England, in US, Russia, everywhere, nimodipine is what is used, right? And the way you know this is, say for instance, let me tell you how cerebral vasospasm would, I can pitch it if I was setting an exam question. I'll give you a 21-year-old female, high school or college student, presents during soccer practice or slumped during soccer practice after complaining of severe headache and 2 episodes of vomiting. You know right there, and then I'll say physical examination is significant for neck stiffness and positive chronic sign. And I'll tell you, from there you know this is probably subarachnoid hemorrhage, most likely Berry's aneurysm, right? You make the diagnosis, that's the easy one. And I'll now tell you, 2 days after admission, she wakes up and she's weak on the right side. You know that Berry's aneurysm will not give you weakness, right? The only thing that can give you weakness from hemorrhagic stroke is the miliary aneurysms, Richard Barker one, right? And this is a 21-year-old kid. She's not hypertensive. And I'll now tell you what are the differential diagnoses. What is the most likely? I'll give you Richard Barker, I'll give you Berry's aneurysm, I'll give you cerebral vasospasm. Your answer in that case will be this stroke has come as a result of cerebral vasospasm as a complication of subarachnoid hemorrhage. You got that? So you got to now pay attention to these things. That's how the picture can be painted, and it will be a good picture.
So you said there's only weakness in hemorrhagic strokes from the miliary?
Yeah, yeah. Only the Charcot-Bouchard aneurysms give you those kind of weakness. Generally speaking, subarachnoid hemorrhages don't give you weakness. Right? Good. Or the other picture I can paint is a beautiful picture. Is tell you a 68-year-old hypertensive diabetic was at a party and he started falling to the right, and his friend held him up, and then he fell to the ground and had a seizure. And when you examine him, he has positive Koenig, positive Brunzinski, and he has neck stiffness, and he was unconscious. Okay. The story says he was dancing. He started falling to the right. So weakness came first, right? And then when he hit the ground, he had a seizure. He bled. We know he bled. But where did he bleed first? He bled intracerebral. That's how he had a weakness. And then the blood dissected its way into the subarachnoid space and develops subarachnoid hemorrhage, secondary to that intracerebral bleeding. And that's why you will have Koenig's neck stiffness. So see, I mean, if you really understand this, there's so many ways somebody can paint the picture for you. And if you really understand what is going on and how it happens, you'll figure it out every single time. You got that? But of course, what you're afraid of the most in hemorrhagic stroke is rebleed. Because invariably, various aneurysms are not one. Charcot-Bouchard are not one. It's not one aneurysm. Many times it's more than one. So, and if one has bled, what stops the other one from bleeding right then and then too? So aneurysmal rebleed is something you are always afraid of whenever you admit patients for aneurysmal stroke. And there are some things that we know now that help us to predict who is likely to rebleed so we can be more aggressive in the management of those patients. High systolic blood pressure, presence of hematoma, aneurysms in the posterior circulation, and when the aneurysm is more than 10 millimeters in diameter, that person is more likely to bleed in that admission. If they have hematoma, elevated blood pressure, aneurysm is more than 10 millimeters. Very important point. Hunt and Hess, two guys as far back as 1968, they developed this grading system to predict the prognosis and outcome in patients with subarachnoid hemorrhage. Who will survive, who will die? Grade, criteria, index, FYI. How do you prefer this? What do you do? Well, somebody is bleeding their brain and they have hypertension. What do you need to do? Take the blood out. There's nothing else to do. Surgical evacuation, intracerebral surgical evacuation, especially if the diameter of the bleed is more than 3 centimeters, that is significant. You should take it out. If your patient has less than 3 centimeters, but the bleed for them cause them to lose consciousness, that is significant. And if your patient has a long life expectancy, you want to do that. Okay? Subarachnoid hemorrhages, you do angiography. What do you want? Why are you doing angiography? You want to identify the aneurysm, right? And then you take care of the aneurysm. That's why we do angiography. You want to see if it is angiography, is it an aneurysm, is it an AV malformation, and depending on what you find, you deal with it. In intracerebral, you don't do angiography. It has nothing to do. There's nothing. You have to evacuate the blood. With subarachnoid, you do angiography to deal with the specific problem. If it's an AV malformation, you may have to resect it. You may have to embolize it, or you might do stereostatic radiosurgery using gamma knife. Aneurysms, you always clip, surgical clipping, or you can do endovascular coiling. Endovascular coiling is what most people do now because it's easier. Radiologists can do it. You don't need neurosurgeons to do it. Again, you monitor the intracranial hypertension exactly the same way like you do for ischemic stroke. This portion of this slide is exactly the same thing as the one we talked about earlier. Okay? This is what it looks like. See a normal AV junction, look at an AV malformation. Not only is there a lot of them, they are tortuous, and this, they are weak, they're big, they're weak, and they bleed. That's why they bleed. Okay? Okay, so you see, this is endovascular embolism. So basically, you put a catheter, you do angiography, you identify the malformation, then you put dirt. This is dirt, plastic, particle, whatever. Put that in there, and you close this, and you cause a clotting like this. And once you clot, you cause blood to clot here, what happens? It gets fibrosed, forms scar tissue, the vessel is closed completely. Okay? Embolized. Or you do what is called stereostatic radiosurgery. You get a bunch of rays, and they use all these devices to focus it on the, it's like laser surgery, right? The gamma rays are focused on the lesion. Of course, you've done your MRA, you identify the lesion, and you map it out, and then you send the patient to the intervention radiologist, who now, they have their machine that develops the gamma rays and focuses it on the lesion, and it burns it. And we call it gamma knife surgery. Now, hemorrhagic stroke. There are lesions that can predispose you to them. And if you can identify those lesions and screen the patient for it, you can actually treat the aneurysm before it ruptures at all. That is the best thing. That is why everybody with adult polycystic kidney disease must be screened for aneurysms. Under normal circumstances, these aneurysms are small. They have low risk of rupture, but you monitor them. If there is a history that that person's relative has bled from those aneurysms in the past, you don't take it for granted. You monitor those aneurysms. Once they exceed 10 millimeters, you send them for prophylactic treatment, either with gamma knife, endovascular, coiling, clipping, whatever you have to do. You screen them for it. So it's extremely important that you screen patients with adult polycystic kidneys for aneurysms, because they are indeed associated with aneurysms and coarctation. Okay? Coarctation of the aorta. Okay. You good? Excellent. You don't have this slide?
No.
Well, you don't need it. Because I think this slide is a repetition of the previous slide. Yeah. Yeah. I'll delete this slide. Okay, so that's the lecture. I have some questions. So, 64-year-old male hypertensive with sudden onset headache and weakness. What is this? Exactly, a hemorrhagic stroke, you see? Now let's mark this one. This is the deal.
Did you say hemorrhagic stroke doesn't lead?
Huh?
Did you say hemorrhagic stroke doesn't lead to weakness? Or are you talking about or is
That's
it
a
miliary?
side.
Oh, okay. Sorry.
Really?
I was confused. I was confused on the last one.
Shoot him.
Did you just have lunch?
Yes.
Okay, that's why. This is a bleed
Right.
because it's bright. It is happening within the brain. So it's an intracerebral bleed, most likely coming from Charcot Bushes, right?
Right. Something like
Got
that.
it. Okay, good. So it's a hemorrhagic stroke. All right, now redeem yourself.
What's that?
Say redeem yourself.
Left hand.
Yeah, I'm giving you an opportunity for redemption. So just take this one only. Left hemiplegia with a right lateral gaze palsy and a left internuclear ophthalmoplegia. Where is the bleed? Or where is the stroke? This is somebody with left hemiplegia with a right lateral gaze palsy.
The right palsy.
Good. Good. Any disagreements? Do you have the answers?
No.
You don't? Okay. Okay, I'm just making sure. Because sometimes I'll leave the answers there and I'll be asking the question. All right. Colin? Here is the right hemiplegia with an upper sparing facial nerve, right facial nerve palsy. So right hemiplegia and a right facial nerve palsy, upper sparing. Both the facial nerve and the body weakness are on the same side. So where would that be? Is that a cortical or a brainstem stroke? Exactly. So it's the fact that everything is on one side means it's a cortical stroke. So is it on the right or is it on the left? Exactly. So right hemiplegia with an upper sparing right facial nerve palsy is left hemispheric stroke. Right? You got that?
Yeah.
Okay. Christian, loss of pain and temperature sensation on the left side of the face and the right side of the body.
Left medullary.
Loss of pain and temperature sensation on the left side of the face and the right side of the body. You say left medullary?
That's what he said. Yeah.
Everybody agrees?
Yeah.
Really? Okay, wait. What fiber carries pain and temperature on the face? Is trigeminal, right? Where does trigeminal come out from?
Spawns.
Okay,
It's like
so
the pons-
if trigeminal is a pontine problem, right? Will it, and it is going to affect the spinothalamic tract? Is it going to be the spinothalamic tract on the same side of the body or the opposite side of the body?
Same side as cranial nerve? Doesn't. Oh,
No.
because it's
On the same side.
same side. Yeah, cranial nerves uncrossed.
I understand that, but listen to my question. For pain and temperature on the side of the face, it's carried in trigeminal, right? So because it's on the left in the face,
So
you agree it's
left
left.
pointing.
Exactly. It's left pointing, but the spinothalamic tract that will be affected are the ones that are from the opposite side of the body. Are you with me?
No.
Okay. The patient loses pain and temperature on the left side of the face. Trigeminal is out. Trigeminal comes from the pons, right? So it's on the same side. So that means this problem is in the pons on the left side. But the patient loses the same sensation on the right side of the body because the spinothalamic tract, they accusate and they ascend on the opposite side of the body. So the spinothalamic tract are the fibers that are subserving the same sensations from the body. They cross as soon as they enter the spinal cord, right? That is why the loss in the body is on the right side, even though it's on the same side in the face. You got it? Are you with me?
Yeah. Maybe if you explain the
But what
other
about
ones.
Wait. I mean,
We'll keep going.
that's just number 3, right?
Yeah, you're right.
We have 2 more. Right. I don't want you to eliminate here. You need to know what you're talking about here. Now, left hemiplegia with an upper sparing left facial nerve palsy. Exactly, right? And the very stroke. It's on the same side, right? Everybody clear on this?
Yeah.
And then right hemiplegia with a left lateral gaze palsy.
I don't think it's some sort of ponting, like a lateral.
Right hemiplegia. Right hemiplegia with a left lateral gaze. What is left here? What have we used?
It should be medullary because 3 should be medullary.
Wait, say it again.
3 should be medullary because it's the Wallenberg syndrome. And then the 5 should be left ponton.
Left ponton stroke, you're right.
Messing
Who,
me up.
who did I shoot down?
He's so sad now. Look at him.
My hand in hand.
Extra credit?
No extra credit. Okay. So this is, you don't have this slide, right? So you can fill it in now. So this one, these 3 is really left with left because that is really Wallenberg syndrome. Wallenberg, what we're talking about. Sometimes I set this question so hard. I can't do it. Exactly. Okay, so but are you clear on why the answer is the answers?
Yeah.
It's a good thing that we figured it out. That wrong one. That right hemiplegia with the left lateral gaze is really the. I think I really like the fact that and remember that this is Wallenberg syndrome. If you remember the Wallenberg syndrome, that's the lateral medullary. 74-year-old female diabetic with sudden onset, one-sided weakness. Good, ischemic stroke. How about this? We're going to mark this. Silent stroke, intracerebral, subdural, subarachnoid, epidural. Good. Are we good? 40-year-old sudden death survivor on CCU admission for cardiogenic shock. What do you see here? Even if I didn't give you this, what picture am I painting here for you? Watershed. But look at the impact. Right here, and right there. Okay? This is what is called watershed infarction. Okay? Excellent. 45-year-old female security guard was brought in by the paramedics in coma. She had suffered a blow to the back of the head and passed out for a few minutes earlier in the day. She had refused to be taken to the hospital at the time because she felt fine after she woke up, until a few hours later when she was found unconscious on the floor in the parking lot. Now, which of the following statement is true about this patient? The patient has suffered a hemorrhagic stroke. Is that true?
C.
Good. Good. Christian said the patient exhibited a diagnostic lucid interval. That's the answer. So this building has 708 bedroom. Right?
Yeah.
Good. I think that's the last one. Now this is the last one. You want to do this? Who said no?
Tia.
Okay, so okay, you're gonna do everything there. So you're gonna match every single one of them. Eh?
We'll help you.
Yeah, we'll help. Okay,
One.
It's B.
One is what?
And 2 you're through. Yeah.
One
Two.
is you're communicating.
Yeah, you're doing it by yourself. And you don't know? Okay, so you're going to take this. You got?
That's fine, I can add to it.
And you're going to turn it into me when I come back in an hour. Why don't you want to try?
Because I haven't reviewed it, so if I review it, I can totally do it.
Okay, so let the class bail you out. The class to the rescue.
Yeah.
One is anterior communicating,
That's right.
and 2, and 3.
Internal carotid. Internal carotid.
Good. 4.
Middle.
Exactly. 5. Posterior communicating, right? 6.
Posterior.
Okay. 7. 8. Superior cerebellar. Good. 9. Pontine. Okay. 10. Good. 11. Anterior cerebellar. Good. 12. Good. I just thought it will help you refresh your memory. Maybe I will now.
That's fine.
Go ahead. What, 10 swings?
Yeah? 10-point question. That's what you're going to get.
That's fine. That's extra credit. That's like extra credit.
Huh?
That's almost like extra credit.
Yeah.
Free real estate.
Vinny, what's going on? I'm trying to get my stuff out. Oh, I got it. I can't see it here, but I can see it there.
Yeah, because it's like extended again. Now it should be back then.
Yeah, it is.
You might have to close it before it lets you do it.
Yeah, get a smaller brush, dog.
What's up? Yeah, get a smaller brush.